Hello, welcome to Definitive Innovation in Resectable Head and Neck Cancer, New Immunotherapy Approaches in Locally Advanced Head and Neck Squamous Cell Carcinoma. I'm Barbara Burtness. I'm a medical oncologist and professor at Yale Cancer Center and Yale School of Medicine in New Haven, Connecticut. And I'm joined today by Dr. Burtness Uppaluri, Brigham and Women's Hospital Endowed Chair in Otolaryngology and professor in the Department of Otolaryngology Head and Neck Surgery at Harvard Medical School in Boston. I'd like to thank PeerView for providing this session and Merck and Company for providing the educational grant behind this symposium. I'd like to give you a reminder to look out for additional polling that will happen during the presentation and to try to answer the polls when they appear on your screen. I also want to let you know that you can submit questions through the chat window and we will answer them throughout this broadcast. You can visit us at peerview.com/2025HNC. And the slides and practice aids can be accessed in the activity menu now, and they can be downloaded after the session. If you need more information, you can send an email to live@peerview.com, and you can join the conversation on X at peerview. So I'm going to start with an introduction focused on the need for immune innovation in locally advanced head and neck squamous cell carcinoma. And we'll start by saying that there is some prior experience about outcomes after chemoradiation. Major phase 3 trials have established radiotherapy with concomitant cisplatin after surgery as the standard of care for high-risk locally advanced head and neck squamous cell carcinoma. And most of us would define that as those cancers with positive margins, those tumors where there's extranodal extension, and those tumors with very high node number, 4 or more. Despite adjuvant postoperative chemoradiation, roughly a third of patients relapse within a year, and overall the 5-year overall survival after chemoradiation for HPV-negative cancer is 45%. We have seen some trials in HPV-associated cancer, like the ECOG-ACRIN E3311 trial, where excellent outcomes with adjuvant chemoradiation were obtained, but as I mentioned, that's a different disease, really. So a question that people have been attempting to address for some time is, can immunotherapy make a difference in the definitive setting, and particularly in those high-risk HPV-negative patients? Certainly, we have prior evidence that has established anti-PD-1 therapy as an immunotherapy standard in recurrent and metastatic head and neck squamous cell carcinoma. And the current standard of care was established by the KEYNOTE-048 trial. In this study, patients who had recurrent or metastatic head and neck cancer that was not amenable to definitive local therapy were randomized either to receive pembrolizumab alone, to receive pembrolizumab plus chemotherapy, or to receive a standard of chemotherapy and cetuximab, the so-called extreme regimen. And across this study, there was a benefit for the use of pembrolizumab. You see here in patients treated with pembrolizumab monotherapy who had PD-L1 expression with a combined positive score of 20 or higher, that the median overall survival went from 10.8 to 14.9 months, and that was highly statistically significant. As well, in the patients with CPS1, there was an advantage for the use of pembrolizumab monotherapy, taking median overall survival from 10.4 to 12.3 months. For all comers, pembrolizumab was non-inferior to cetuximab chemotherapy, but if we did an analysis focused on the PD-L1 less than 1 population, pembrolizumab monotherapy was not beneficial in that group. However, in the other analysis within this trial of pembrolizumab plus chemotherapy was beneficial across all PD-L1 groups. So NCCN recommendations for systemic therapy for non-nasopharyngeal head and neck squamous cell carcinoma now indicate that pembrolizumab is preferred. So in the first line, pembrolizumab with doublet chemotherapy based on cisplatin or carboplatin and 5-FU is category 1 for all patients. Pembrolizumab monotherapy is also category 1 for patients or for tumors that express PD-L1 with a CPS of 1 or greater. We have also seen in the B10 trial that the chemotherapy can be a platinating agent with a taxane. For those patients who've received first-line treatment for recurrent metastatic disease, that did not include a PD-1 inhibitor, a second-line treatment with nivolumab or pembrolizumab, independent of PD-L1 expression, is also NCCN recommended and FDA approved. So our goals for today are to look at the increasing evidence that supports the use of immunotherapy in locally advanced head and neck squamous cell carcinoma, including in the neoadjuvant and adjuvant settings. How we approach integrating perioperative immunotherapy into treatment protocols, and how this should be done in collaboration with members of a multidisciplinary team that includes medical oncologists, head and neck surgeons, pathologists, and advanced practitioners, and how important attention to timing, dosing, and safety considerations are to ensure effective delivery of perioperative immunotherapy for patients with locally advanced head and neck cancer. And so to dive more deeply into the evidence for adjuvant and neoadjuvant immunotherapy, I'm happy to turn this over to Dr. Uppaluri.
Thank you, Dr. Burtness. I'm excited today to join you all and talk about evidence for evidence for innovation, specifically with advances with adjuvant and neoadjuvant immunotherapy in the resectable, surgically managed, locally advanced head and neck cancer squamous cell carcinoma setting. So before we get into the actual details of the recent exciting findings, I want to take a few moments to talk about the mechanisms of neoadjuvant immunotherapy. Now, this is a completely new paradigm with respect to how we're going to integrate this in the surgical management of head and neck cancer patients. So I want to take a moment to talk about what mechanistic aspects may be contributing to the potential benefit of neoadjuvant immunotherapy in this context. So a significant amount of preclinical data and now clinical experience suggests there are two mechanistic aspects for the effect of a neoadjuvant immunotherapy in the context of a pre-surgical approach for patients with head and neck squamous cell carcinoma. First, there's this concept that there's a pre-existing anti-tumor immunity that can be unleashed by the addition of checkpoint blockade prior to the removal of the tumor bulk or draining lymph nodes. And this results because of natural priming that happens in the natural context as tumors develop. And there's a T cell response that's pre-existing that can then be accessed by delivering anti-PD-1 or other checkpoint blockade immune therapy. This direct cytotoxicity, as shown in this slide, can then lead to pathologic responses, which we'll talk about in the next few slides also. A second and almost equally important aspect of neoadjuvant immunotherapy is the idea that immune checkpoint blockade prior to surgical removal, where the tumor antigen burden is in place, with the functional and intact lymph node axis, can provide a sort of a vaccination effect with enhanced durable immune response. So as shown in the schematic at the bottom here, what you see is that delivery of neoadjuvant immunotherapy prior to surgery can reinvigorate the anti-tumor immune response, and that can persist through the resection phase and then beyond in the adjuvant phase also. So these principles are really the foundation of how we think about neoadjuvant immunotherapy. So we and others have now completed multiple studies looking at this concept in locally advanced resectable HPV-unrelated head and neck cancers. And this slide highlights a few of the studies that have been published testing this paradigm. And importantly, all these studies have been consistent in showing that there's a potential signal here of delivering neoadjuvant immunotherapy prior to surgical resection for these patients. Some of the data from our study with myself and Doug Atkins at Washington University School of Medicine are shown here. So one of the key features I mentioned that is observed with neoadjuvant immunotherapy is this idea of pathologic tumor responses. And that is evidence seen in standard histologic and pathologic evaluation of the resected primary tumor and lymph nodes after delivery of 1 or 2 doses of neoadjuvant immune checkpoint blockade. So in our phase 2 trial that was published in this Clinical Cancer Research in 2020, what we showed is that there were pathologic tumor responses with a grading scale here that we called of PTR2, which is effectively 50% or greater of the tumor bed being showing these features of pathologic changes related to neoadjuvant immunotherapy. And what we noticed, interestingly, was that both the low/intermediate risk patients and the high-risk patients that Dr. Burtness talked about earlier, those with positive margins and external extension, appeared to have pathologic tumor responses to neoadjuvant immunotherapy. This translates in a subset of patients into these dramatic findings that are shown in the middle panels and the far right panels. What you see here is a exophytic buccal squamous cell carcinoma that at baseline is shown by the red circle here. And what you see after a single dose of neoadjuvant immunotherapy is a significant reduction in the tumor bulk that was visible at baseline. Now, these kind of features do translate also to imaging findings as shown on the right side, where these bulky matted lymph nodes appear to involute after even, again, a single dose of neoadjuvant immunotherapy. These kind of features are not the rule in head and neck cancer. We most often see pathologic tumor changes. These large changes are not frequent, but do illustrate that. But these figures do illustrate that it does happen, and it's something that we will be seeing more of as these regimens are integrated into our standard of care. So these foundational studies, ours and many others, really led to Keynote 689, and the schema for this trial is shown in this slide. So Keynote 689 enrolled adults with resectable, locally advanced stage 3 or 4A head and neck squamous cell carcinomas. These were oral cavity, a small subset of oropharynx patients, hypopharynx and larynx cancer subsites. Patients with this disease, these patients who qualified were then randomized, as shown here, into patients receiving standard of care therapy, which is shown in the bottom arm, or to those who received 2 cycles of neoadjuvant immunotherapy, and both arms then underwent standard of care surgery, as shown in the purple bar in the middle here. Based on pathology from the resected primary tumor and lymph nodes as a standard of care, patients then received either primary adjuvant radiation or adjuvant radiation plus cisplatin, as defined again by the current standard of care. In the pembrolizumab standard of care arm, patients received concurrent pembrolizumab along with their chemotherapy and radiation, or radiation alone, and then were given maintenance pembrolizumab of 12 cycles, as shown in the top part of the schema. The stratification factors are shown on the bottom left side. The primary endpoint was event-free survival, that is, recurrence or death after the time of randomization in both arms in the intention to treat population. And this is done by blinded independent central review. We also looked at key secondary endpoints of major pathologic response, again by blinded independent pathologic review, and also overall survival. Additional endpoints included safety. The results were published earlier this year in the New England Journal of Medicine, and these were shown for 3 different CPS scores across the population. I'll start in the middle portion here. Sorry, in the left graph here, showing that in the Kaplan-Meier curve, event-free survival, specifically at the 3-year landmark time point in all patients enrolled in the trial, was 57.6% in the pembrolizumab plus standard of care arm versus 46.4% in the standard of care arm. This finding was also observed in the CPS 10 or greater population and the CPS 1 or greater population. The hazard ratio in all 3 tested populations and the significance value are shown in the slide and met the intention to treat significance boundary in the pre-specified protocol statistical analysis plan. Thus, these findings represent level 1 evidence for the support of addition of perioperative immunotherapy into locally advanced head and neck cancer squamous cell carcinoma patients who are planned for surgery. Subgroup analysis from the Keynote 689 is shown here, with all the specific caveats of the appropriate powering of these studies, and also that the correct correction for multiplicity. These data still are insightful in showing that EFS benefit was seen in across the subgroups analyzed in these forest plots shown here. In addition, data presented at ASTRO by Dr. Nancy Lee highlight additional key findings from Keynote 689. In the previous slides, in terms of event-free survival, I showed data for all participants, including the low and high risk populations. And further, again, subgroup analyses that were completed, we see here that both the low risk patients and high risk patients appear to benefit from the addition of perioperative immunotherapy to the surgical approach. So this is an important slide, again, highlighting that all patients appear to benefit from this approach, not just the low risk or the high risk patients. Importantly, a key finding from this trial has significant implications for de-intensification approaches in the locally advanced head and neck cancer setting. Specifically, pathologic assessment by a blinded independent review showed that patients who received pembrolizumab as standard of care had a 32.5% incidence of high-risk features, that is, positive margins or external extension, versus 44.4% in the standard of care arm. This difference is really meaningful for patients in terms of potentially de-intensifying their adjuvant therapy. And in fact, that's what was observed in looking at the radiation dose shown here. So what you see is that overall, patients in the pembrolizumab standard of care arm received a lower median dose of radiation of 60 gray versus 66 gray in the standard of care arm. Of those patients who were deemed to receive cisplatin, the same dose was given as in the control arm. So importantly, this highlights that fewer patients in the pembrolizumab arm needed cisplatin because of fewer high-risk features, and overall highlights again that this approach is a key de-intensification approach for a subset of patients treated in this fashion. The safety data are shown here. Overall, I want to highlight a couple different features from these data. First, because of the extended treatment course of the maintenance pembrolizumab, etc., the patients in the pembrolizumab standard of care arm were monitored for 9 months versus about 3 months in the standard of care arm. Despite this extended monitoring window, the grade 3 or higher events were similar between the pembrolizumab standard of care arm versus standard of care arm. The immune-mediated adverse events are shown at the bottom, and as expected, patients who received neoadjuvant and adjuvant pembrolizumab had higher rates of immune-mediated adverse events. It's an important point to highlight because this is an expected potential side effect of immune checkpoint inhibition, and it's something to be monitored for closely in these patients. Having said that, the majority of these patients that had these events were managed satisfactorily, but it is something to be aware of in these approaches. These findings have now led to the addition of perioperative pembrolizumab to the NCCN guidelines as one option for these patients, including in select resectable oral cavity cancers and the other key features shown here. Before we move on, please take a moment to answer follow-up polls on the current evidence supporting perioperative immunotherapy in locally advanced head and neck squamous cell carcinoma. I want to take a few moments here to also talk about future directions with neoadjuvant immunotherapy. There are many different trials currently ongoing that are assessing additional combination approaches in the neoadjuvant setting, given the 689 findings. These include immunotherapy combinations, that is, adding additional immune checkpoint inhibitors to the anti-PD-1 backbone. And there are also additional trials testing the addition of chemotherapy along with immunotherapy in the neoadjuvant setting. A recent presentation at the European Society of Medical Oncology meeting included the phase 2 CAMORAL study, which tested the addition of neoadjuvant and adjuvant pembrolizumab, an anti-PD-1 agent, in locally advanced head and neck cancer. This study involved a randomized approach where patients with locally advanced stage 3-4 head and neck cancer, similar to the Keynote 689 population, were randomized to standard of care in the bottom arm versus receiving pembrolizumab plus chemotherapy in a neoadjuvant approach. Again, both arms underwent standard of care surgery, and then the patients in the standard of care arm received adjuvant radiotherapy and cisplatin based on pathology-directed findings. The patients in the experimental arm received also radiotherapy and cisplatin, but also were then maintained on adjuvant pembrolizumab, as shown here. The primary endpoints of this trial were 2-year event-free survival assessed by the investigators. These data really showed dramatic improvement in the event-free survival with the addition of chemotherapy to pembrolizumab, as shown here in the red line, compared to standard of care arm below, with the hazard ratio as shown here and a highly significant p-value. So these data really highlight one specific study and one specific approach that is being studied in the context of improving neoadjuvant immunotherapy approaches for head and neck cancer patients. So the additional question comes up, is there progress in developing adjuvant immunotherapy for locally advanced head and neck cancers for those patients who have undergone surgical resection? And an additional exciting report this year from ASCO was the NIVO post-op study completed by the Gortec group from France. This study tested the addition of adjuvant nivolumab to standard of care chemotherapy and radiation in adults with locally advanced head and neck cancer after complete resection. The focus of this study was really on these very high-risk patients with positive margins or external extension. And so patients had already undergone complete resection, and pathology had identified these patients to have high-risk features, as we've discussed. Patients in this study were randomized to receive adjuvant cisplatin plus radiation, which is a standard of care, or were randomized to receive nivolumab as a loading dose, followed by concurrent with and then maintenance nivolumab, as shown in this schema here. The primary endpoint of this trial was disease-free survival. This slide highlights the details of the patients enrolled in this trial. And what you see first is, number one, that the majority of these patients were oral cavity patients, which is an area that we all have challenges with. In addition, these patients were very advanced, locally advanced patients. As you can see, that nearly half the patients were stage 4B, pathologically stage 4B patients, suggesting this is a very high-risk group of patients that was enrolled in this trial. And the second red box below highlights the external extension or positive margin rate in these patients, again, showing that as for the inclusion criteria, many of these patients had these features, all these patients had these features, with some having both features also. They also obviously included here multiple lymph nodes or peritoneal invasion as an additional risk factor for receiving adjuvant nivolumab. The addition of nivolumab improved disease-free survival, as shown in this Kaplan-Meier curve. As you can see, patients at the 3-year landmark time point of 36 months had a 63.1% rate of disease-free survival versus 52.5% in the standard of care arm. This translated to a hazard ratio of 0.76 and a p-value of 0.034, which met their pre-specified statistical plan, and this was a positive study also. Interestingly, the authors showed that nivolumab addition to chemoradiation significantly improved local regional recurrences with a hazard ratio of 0.63. In NIVO post-op, addition of nivolumab to chemoradiation did not worsen acute chemoradiation-induced toxicities, as shown across these different domains that were assessed. In summary, this has been a really exciting year for patients with surgically resected locally advanced head and neck cancer, in the sense that several different developments highlight a real opportunity to improve outcomes for these patients. So, Dr. Burtness, I think it would be really insightful for us to look at a real-world practice and how we apply these principles in locally advanced head and neck cancer.
Great. Thank you, Ravi. So this is a case of a patient who presented with locally advanced head and neck squamous cell carcinoma. 23-year-old man, never smoker, and he gives a 4-month history of having had a non-healing lesion that progressed to a mass on the left tongue. A biopsy of the left tongue is performed, and it shows an invasive squamous cell carcinoma that's moderately differentiated. There's no lymphovascular or perineural invasion. PD-L1 testing is performed on that initial biopsy, and it shows a combined positive score of 15. The patient is seen by the surgeon and as well undergoes a multidisciplinary team evaluation. the team recommends a PET scan, and you see that here. So illuminating not only the fairly substantial tongue mass, which seems to, at a minimum, abut the midline if it doesn't even begin to cross it a little bit, as well as some clear ipsilateral lymph nodes. So I think, Ravi, I would love to hear your thoughts about the next step. And I think, what a lot of us are wrestling with in our tumor boards is for which patients should the Keynote 689 approach be prioritized? Are there any patients where you start out thinking about Nivo post-op, or is Nivo post-op more for when you're surprised? And so just sort of love to hear about how you would approach a T3N0 stage 3 cancer with, at least on the biopsy, no evidence of multifocal perineural invasion.
Yeah, thanks, Barbara. So a few different points here, I think, to discuss. First, obviously, this is an unfortunate case for a 23-year-old to have this, and that's, to me, that's also raises my antennas a little bit about concerns about the biology of this disease in a young patient. Given this, I think in the staging, we would obviously have a multidisciplinary discussion about options for management. A primary surgical approach would be recommended for this patient. And then the question is, do we consider Keynote 689 for this patient? With the data that I've shown, I think that this patient would qualify for this, and that would be our recommendation to enroll this patient in a Keynote 689 regimen for a few different reasons. I think that the surgery alone approach followed by adjuvant treatment based on pathology would obviously have be the previous standard of care. But at this point, with the 689 data, I believe that this patient could benefit from that approach, potentially with including with de-intensification. So I think a 689 approach would be very appropriate for this patient.
There's a subset analysis from Keynote 689 that seems to indicate a particularly favorable hazard ratio for the patients with stage 3 cancer. And I understand that's a minority of the patients on Keynote 689, and study certainly wasn't powered to independently answer questions in stage 3 and stage 4 patients, but that forest plot does give me to think that patients with stage 3 disease really benefit from perioperative pembrolizumab. And a patient like this is unlikely to meet the test to have immunotherapy incorporated into their management if you go straight to surgery and rely on Nivo post-op. We saw in the PET scan, it looked like 2 nodes were involved. The biopsy doesn't seem to indicate extensive perineural invasion, and you're looking at a stage 3 cancer. So I almost think that you could argue that if you kick the can down the road and try to rely on post-op therapy, you're depriving this patient of a significant improvement in event-free survival that would have come from the inclusion of immunotherapy.
Yeah, I mean, I agree with you that with all the caveats of the subgroup analyses and these concerns, having said that, there is this clear suggestion that stage 3 patients definitely would benefit. And in particular, also the additional data presented at ASTRO by Dr. Lee showing that the low/intermediate group also benefits from this approach. So I think all those put together, I agree that the 689 regimen would be, this patient would be an ideal sort of candidate for the 689 regimen.
Another question I wanted to ask you, which has not that much to do with immunotherapy, I guess, but 23 is quite young in a non-smoker. And I guess the 2 things that pop into my head first off are, 1, was this person vaping on a daily basis? And 2 is, did you exclude Fanconi anemia? So sometimes that can be hypomorphic, and patients have never needed a bone marrow transplantation, and cancer can be the first presentation. And I guess you'd want to know that before you embarked on the post-op radiation.
Yeah, for the latter question, I think we all sort of ask that question immediately for the young patient, and we do perform testing for that, especially given the likelihood that he would need adjuvant radiation. In terms of the additional risk factors that you mentioned about vaping, et cetera, I don't believe this patient had a vaping history, but again, I think that some of these other sort of questions about what the risk factors could be are still sort of being investigated. So I'm not sure I can say 100% that that's correlated here. But having said that, this patient did not have vaping history. Yeah. So yeah, I think that, again, based on the points that we discussed, this being a stage 3 patient, a young patient who really shouldn't be getting these cancers, all these things put together, I would consider this patient a very good candidate for the 689 regimen.
Maybe another thing I'd like to comment on is, I think when you designed Keynote 689, it was a little bit unknown whether or not the intensity of post-op therapy should be determined by the baseline characteristics or by what you found at the time of surgery. And obviously the design of 689 was not focused on answering that. I think we probably still have room for a trial that asks if post-op therapy should be guided by baseline characteristics or surgical pathology. But certainly the group that got neoadjuvant pembrolizumab, which included a higher proportion of patients who didn't need 66 gray, 13% was at lower risk of needing cisplatin. Certainly that group did better despite the deintensification. So I think we haven't fully answered the question of whether or not the deintensification is the best approach, but we have shown that even with deintensification, this group of patients does better.
Yeah, this is a great question. I get asked this all the time from a few different levels. First of all, from a surgical standpoint, we wrote the trial saying that resection should be performed to the original margin. So you're still treating the original margins despite the response. From the adjuvant therapy standpoint, again, we wrote the trial with, what was the best sort of evidence at that point, which was go based on the pathology-directed treatment rather than what was there at the beginning. And again, that's a key question that I've been asked also with respect to saying, should you have treated also to the initial sort of findings? But again, when we wrote the trial, that's what we had. That was our understanding, in trying to sort of define response-adapted criteria, both from a surgical standpoint and from an adjuvant therapy standpoint, was not even a consideration at that time. Now with these data, I think both these questions can be looked at more closely. In particular, as a surgeon, I can comment on the response-adapted piece that should we be doing smaller surgeries at some point in these patients? I think those questions we didn't ask in 689, but definitely now that we have these data are something that we should think about more in designing future trials.
And certainly anecdotally, once in a while we get away with it, right? I mean, I think there has been some modification of surgical approach in some patients, despite whatever the dogma might be.
Correct. Yeah. I can give you the textbook answer. Let's put it that way.
Right. Perfect. Okay. So if we then look at how this patient did, so you see at baseline, the tumor had measured 2.4 centimeters in its longest dimension, and after neoadjuvant therapy, measured 1.9 centimeters in its longest dimension. And clinically, there was also evidence of a response. So you see at the left, the tumor at baseline. In the middle, you can see some regression and maybe even some, it looks like some fibrosis developing after cycle 1, and marked further regression after cycle 2. So the patient was taken to partial glossectomy, neck dissection, free flap reconstruction. Post-surgical pathologic stage classification showed a tumor that was 2.8 centimeters in size with a depth of invasion of 9 millimeters. Looking at the percent remaining viable tumor, this tumor was classified as a PT2, and 0 of 45 lymph nodes were involved. Perineural invasion was present. Lymphovascular invasion was not present. The closest margin was the deep margin, and that was 0.1 millimeters. So the question here is concurrent chemoradiation and pembrolizumab, and sort of what is the timing, what is the workflow on that? So I'll let you have a first crack at that, Ravi.
Yeah, a few different things. Just a real quick comment about the pathology here. The 60% viable tumor is kind of what we see in terms of this partial response, is what we saw in many other patients in our phase 2 studies. And I think this is what is seen oftentimes in head and neck cancers with monotherapy anti-PD-1 approaches. Again, highlighting that, going back to my initial sort of a description of the mechanism of neoadjuvant immunotherapy, this is what is evidence of that, is that there's something going on that starts the anti-tumor immune response that progresses it through in terms of maintaining and improving outcomes. Specifically with the pathology here, and again, we talked about pathology therapy, the main concern here is to me is the deep margin, obviously, which is 0.1 millimeter. And per the 689 protocol, this patient would have been recommended to undergo concurrent chemoradiotherapy with pembrolizumab. And I think you could argue, again, because of the patient's age and the sort of these high-risk features, including PNI, that addition of chemotherapy to adjuvant radiation would be appropriate here, in addition to this margin issue. So obviously, we would review this patient in our, again, multi-D setting, looking at the pathology, the surgeon and medical oncology, radiation oncology discussing it, and then proceeding with the recommendation.
One of the things, obviously, that was striking about this case was the CPS was 15. The FDA approval so Keynote 689 accepted patients irrespective of PD-L1 status. However, as I recall, over 95% of patients were PD-L1 expressing, and the FDA approval is specifically for patients who are PD-L1 positive. I guess one thing I'd ask you is if you have a PD-L1 CPS 0 case and you take them straight to the operating room because the data are, not there for pembrolizumab in that subset, and you end up with this same pathology report, which I think arguably would meet the Nivo post-op criteria with multifocal PNI and a margin so close that you wonder if it's positive, right? And so for Nivo post-op, although they're also the majority of the patients were PD-L1 expressing, once you have that higher stage, would you be a little bit more forgiving in a PD-L1 negative patient and think about adding the Nivo?
Yeah, as you pointed out, if this patient had been a CPS 0, specifically related to that question, they would not have been on the 689 regimen. And with this pathology findings, I do think they would qualify then for the Nivo post-op regimen. In the Nivo post-op, although they showed the PD-L1 scores across the patients, there was no correlation with outcomes with PD-L1 testing in Nivo post-op. So this patient would be a good candidate for that approach.
I mean, I think it's fair to observe also in Nivo post-op, there wasn't a lot of power in looking at the question in the PD-L1 negative, but I agree, that's how I'd see it as well. And then, another question that comes up is overlapping immune checkpoint inhibitor and radiation toxicity. And I think there's been quite a lot of evidence to date that it is quite feasible to give an immune checkpoint inhibitor during radiation. Certainly the large studies in the definitive chemo RT setting, although they were not positive, none of them had a suggestion that toxicity was really the explanation for that. And both in Keynote 689 and in Nivo post-op, the administration of radiation in the immunotherapy arm was not impaired. So I think you see more hypothyroidism, you see more facial edema, but there are no strong safety signals that indicate that this isn't feasible. So before we move on, we'd like you to take a moment again to answer a follow-up poll on treatment choices in locally advanced head and neck squamous cell carcinoma and the role of immunotherapy in this setting. In head and neck cancer, the goal of a multidisciplinary team is to deliver effective, function-preserving, toxicity-aware, patient-centered care. And so it's just important to highlight how many of your colleagues can help achieve this. So certainly we think of the surgical oncologists, the medical and radiation oncologists. There are advanced practitioners on many of our teams, so advanced practice nurses and physician assistants. Patients with head and neck cancer struggle with nutrition, and dietitians and nutritionists can be helpful. Social workers can be helpful with the logistical challenges, and in some cases, some of the social stressors and determinants of health that patients bring with them to the diagnosis. We talked a lot today about oral cavity cancer, and dentists and prosthodontists have a role in helping to manage these patients. The surgery, the radiation, and some of the chemotherapy agents can lead to swallowing dysfunction. Long periods of disordered swallowing can lead to further loss of strength and coordination in the pharyngeal constrictors. And so speech and swallowing pathologists to help with prehab before the surgery and radiation, rehab during chemoradiation and afterwards, and physical and rehabilitation therapists who can help with shoulder dysfunction, deconditioning, and others. It sounds like at Brigham and Women's and here at Yale, the tumor board and the multidisciplinary conference are really essential to picking our best recommendation for a patient. And this is all the more the case when you're thinking about a patient who's got a fresh diagnosis and you're thinking about scheduling surgery, and you believe that the standard of care for that patient is going to involve 2 doses of preoperative pembrolizumab. So making sure that the patient has access to a medical oncologist really very early on in that diagnostic and decision-making phase is important. And moving these patients into perioperative treatment and scheduling surgery in a timely fashion are really going to be important to implementing this new approach. And so, Ravi, I know you have about as much experience with this as anybody, because you have been doing this since the phase 2 studies. But I wondered if you could visualize a workflow for us.
Yeah, Barbara, again, just in terms of your previous slide, I just want to emphasize again, this taking care of head and neck cancer patients truly takes a village. And this sort of integration of all these different groups is just so critical for this process. And going to the next slide, then, it really does show that that all these pieces working together, especially with the 689 regimen, are really just very, very critical. So what this slide really talks through is a potential workflow for perioperative immunotherapy, given how we would integrate this in the real world practice. A main issue is obviously the diagnosis workup, and in particular, the PD-L1 testing and the CPS scores, which are going to be critical for determining that the patient qualifies for the 689 regimen. So the way we think about it is patients come in and are evaluated in a multidisciplinary setting by surgeons, medical oncologists, radiation oncologists, and if they're deemed to be surgically resectable and considered for this, we almost immediately start thinking about the CPS testing. We often get patients in consultation from outside institutions, I'm sure as many folks around the country do. And so oftentimes they'll come in with biopsies from the outside, which again, that workflow piece with their CPS testing can be an issue. So one thing we've considered is just repeating the biopsy if the patient tolerates it to achieve this. I do think that we're headed to a point at some point where PD-L1 testing will be a reflex test for head and neck cancer patients, but in 2025, we're not there yet. And this is a major sort of issue for most folks. And one way to do that is what we've done is to repeat the biopsies and get that going quicker. And once that's confirmed with the eligibility confirmation with the PD-L1 testing, it's really a key coordination issue then with the surgical piece and the medical oncologists working together and thinking about sequencing the cycles in the surgery. Scheduling the surgery is a complex process, especially for these locally advanced head and neck cancer patients where you need multiple teams involved, including the resection surgeon and the reconstructive surgeon. So given all that coordination, I think identifying the date up front and coordinating that with the dates of the cycle 1 and cycle 2 are really critical. So through this cycle in that number 2 sort of point in the middle portion of this slide, what I've emphasized and we've emphasized to everybody on our team is the involvement of the surgeon during this process along with the medical oncologist in monitoring the patient. So we try to at least have very good communication or actually a clinic visit with our surgeons during that time prior to cycle 2 to make sure the patient is on track with respect to how the tumor is responding, if anything needs to any intervention needs to happen earlier, these kind of questions. So I think that's a very key part of the delivery portion of the 689 regimen. And then, of course, after that, the surgical part is key. And as I've said, we have emphasized that maintaining the original resection margins is important to think about as we learn more how response happens. But maintaining the original resection margins during surgery is a key and important approach in these patients. I will say, just we didn't talk about it earlier, but from a surgical standpoint and again workflow standpoint, we haven't seen any impact of getting patients to surgery or having intraoperative issues or postoperative issues, the wound healing. So I think that part of it is there's a lot of reassurance for surgeons in seeing that data. Then, of course, is the adjuvant phase, it's really centered on the path risk review. And again, we really focus this on working with our pathologists to look at the margins in E&E, of course, to determine the risk stratification piece. In addition, also really looking at this pathologic response that we've talked about previously. I think it's obviously very reassuring for providers and in particular patients to see some sort of active immune response, but we don't always see that, but it's an important sort of feature of our pathologists also commenting on that in addition to the margins and external extension. And of course, then that's the discussion that comes in as we had with our example case that we discussed about the addition of cisplatin to adjuvant radiation, and then obviously the maintenance treatment as shown here. Your thoughts, Barbara, on that?
Yeah, well, the only thing I guess is I see the emphasis on starting radiation within 6 weeks, and I know there have been some retrospective data that have been taken very seriously in the community about that. I think that's a space that could use more data, and I guess I would also imagine that in a patient who's having a very robust anti-tumor immune response, perhaps the importance of that could be a little bit diminished. It's certainly what we strive for as well. But I guess for people who are listening to this, I would emphasize if the patient is not ready for radiation at 6 weeks, so be it. It's still a really important part of managing these patients. What about toxicities? And as we mentioned earlier, we don't think that toxicity is a barrier to taking this approach because it was not a barrier in the definitive chemoradiation studies. It was not a barrier in the phase 2 studies, and it was not a barrier in Keynote 689 or Nivo post-op. But what are the things that maybe present a little bit of a challenge? And one thing, obviously, is that both chemoradiation and immune checkpoint inhibitors can lead to rash. Chemoradiation, I think this is a very classic picture that, physicians won't struggle with. So it's an in-field dermatitis. It intensifies over the course of treatment. It peaks at the end of radiation, and it heals within weeks, albeit you may see recall phenomena. Immunotherapy commonly leads to a mild rash, can lead to a more significant rash, and this is generally maculopapular, although in rare cases, Stevens-Johnson or bullous pemphigoid-like rashes may be seen. In general, we've not been observing, even in the chemoradiation patients, that this would be restricted to the radiation field or that its timing would be as tightly tied to radiation. And then the other thing that we have seen more often in head and neck cancer patients who are treated with immune checkpoint inhibitors, and this is true for patients who receive it in the recurrent metastatic setting, as well as for patients who receive it in definitive or adjuvant settings, is that there can be more facial and neck edema than you're used to. And so The onset of this can be, towards the end of radiation or within a few weeks or months after radiation. And although it is uncommon, it is more common for head and neck cancer patients who are treated with immune checkpoint inhibitors than in other diseases. And the management is not similar to what you might use for a severe rash with immunotherapy, where you might be thinking about adding a steroid. But here it's similar to your classic lymphedema management with elevation of the head, the use of massage, or the use of dressings. In those rare cases where it is affecting the airway, obviously then you would jump in with steroids. Hypothyroidism and thyroiditis are also seen with both modalities. So hyperthyroidism sort of towards the end of chemoradiation or immediately following it. Hypothyroidism beginning weeks or months or even a couple of years after the conclusion of chemoradiation. And with immunotherapy, typically starting 2 to 3 months after the initiation of the immune checkpoint inhibitor. And as with the head and neck edema, the excess incidence of hypothyroidism with immune checkpoint inhibitors is more dramatic in head and neck cancer patients than in patients with other diseases. And we do attribute this to some interaction with the prior history of chemoradiation. In terms of renal toxicity, the heavy reliance on cisplatin in the chemoradiation setting. So there's usually a strong temporal relationship, can be associated with dehydration. You can see magnesium and potassium wasting. And there is quite a lot of acceptance in the field now that patients who are receiving cisplatin and radiation should not only get the aggressive hydration on the day of dosing, but should be getting supplemental IV hydration, some evidence that that can be supplemented with magnesium as well. And immune checkpoint inhibitor renal toxicity being much less common, happening some weeks to months after the initiation of immunotherapy, often co-occurring with other immune-related adverse events, and maybe much more often associated with symptoms and signs of nephritis. Pneumonitis is obviously something that can be seen with immune checkpoint inhibitors, and this ranges from grade 1, where it's really just a radiographic observation with no symptoms, no impairment of oxygenation, and no intervention is needed, as opposed to the chemoradiation and postoperative patients where aspiration pneumonia is a much more common presentation. Well, Ravi, this has been a great discussion. And I think the use of perioperative immunotherapy is really a transformational inflection point for our patients with locally advanced head and neck cancer. I guess, like any good study, it asks as many questions as it answers, or it opens up as many future avenues. And in your discussion, you brought up two things that I think we could maybe delve into a little bit more. And the first is the question of immunotherapy combinations. And so I know there have been some neoadjuvant studies done with both PD-1 plus CTLA-4 inhibitors and PD-1 plus LAG-3 inhibitors. I don't know if there are other things you're excited about on the horizon.
No, it's as you said, it's a really exciting time, I think, in locally advanced head and neck cancers, and 689 really sort of sets the initial sort of bar for that. But I think it's really a time for us now to explore really future options, as you mentioned. So yeah, I think that in terms of the IO combinations or additional checkpoints that could be added, there's a lot of very exciting data in this. And ultimately, the question is, what are we aiming for? And really, it's this pathologic response and priming the immune system. And are there better approaches to doing that is I think the key question. Because if we believe that in this slide that I presented, talking about the mechanisms of what we think is happening with the addition of neoadjuvant immunotherapy in terms of the impact on event-free survival and hopefully overall survival, then it's really that early question of better priming. And can we achieve better priming with additional checkpoints? So there is clearly already phase 2 data suggesting that addition of additional checkpoints, as you mentioned, CTLA-4 and LAG-3, can improve those path responses. So there are two studies, one from here led by John Schoenfeld, and one from the Netherlands with Lotje Zoer, which tested the addition of CTLA-4 to anti-PD-1 nivolumab as an approach for a neoadjuvant approach. Now, neither one of those studies was really powered to test the question of whether addition of CTLA-4 blockade also is better than anti-PD-1 blockade alone as monotherapy. But there's clearly were signals there suggesting that that could achieve potentially higher pathological responses. So that's one direction that we could go. Now, Dr. Bob Ferris recently published also their experience from Pittsburgh, where they tested the nivolumab monotherapy, nivolumab plus ipilimumab, or nivolumab plus relatlimab as a 3-arm trial. And again, intriguingly, they found that that the addition of these additional checkpoints seemed to increase the pathologic response rate, again suggesting that additional checkpoints may be an approach and a strategy to increase path responses and hopefully clinical outcomes. So again, very exciting possibilities, but those are just some examples that are out there right now.
Yeah, I think so much that's going to be very interesting to watch moving forward. One of the things we mentioned about Keynote 689 is the very small number of patients with PD-L1 negative cancer and the very small number of patients with HPV-associated cancer. And so I think given the magnitude of the benefit that this offered in the PD-L1 positive population and the HPV negative population, trials that are specific to those unique populations are probably also warranted, and their additional checkpoint inhibitors, as you've been talking about, the inclusion of chemotherapy, given that we know that chemotherapy plus immunotherapy has such an extremely high response rate in recurrent metastatic HPV-associated cancer. Our group at Yale has been interested in understanding the ways in which methylation leads to immune silencing in HPV-associated cancers. We have an active trial of nivolumab together with 5-azacitidine in that setting. So I think those somewhat unique populations are maybe not addressed by the big trials we have to date, but I think new concepts will be coming for them as well. HPV vaccines, I think, maybe also having a role there. Another thing, maybe I would love to get your thoughts about, Ravi, are the borderline resectable patients. So I know there were very few patients in Keynote 689 who did not make it to surgery on the pembro arm, but there were a few. And given the high response rates with the addition of chemotherapy, is that group of patients with the very locally advanced tumors, are they patients in whom that immunotherapy plus chemotherapy approach has particular promise?
Yeah, I think this is a great question. In particular, I get asked this question often with respect to the borderline resectable patient, and should we use a Keynote 689 regimen in them because maybe they'll become resectable now. And I'd be very careful about this point, in particular that I don't think that the regimen is meant to allow surgeons to operate more on the borderline resectable patients. So I would not recommend this approach for those patients with a very locally advanced disease. So, but I do agree, though, that there's enough evidence now, at least in the phase 2 level, and as you pointed out, clinical experience here that suggests that chemo-IO combinations may be more appropriate for those patients, and I would favor those kind of patients be studied in that context.
Wonderful, thank you. Well, I'll just take half a minute here to recapitulate what we've talked about today. Firstly, that the use of preoperative immunotherapy to prime the immune system and exploit intact tumor draining lymph nodes has a very strong scientific rationale and led to the design of a phase 3 study that tested perioperative pembrolizumab followed by surgery, followed by risk-adjusted postoperative therapy that has shown a significant impact on event-free survival. And for those patients who appear to have clinical stage 3-4 cancer and are clearly resectable, that establishes a new standard of care if the tumor is PD-L1 expressing. For those patients where you don't think that that's mandated, and then the patient ends up coming to surgery and having high-risk features after all, Nivo post-op offers another direction. Toxicity is very manageable with this approach and should not be thought of as a reason not to offer this approach, maybe with the exception of patients with autoimmune disease. And there are many new strategies to explore moving forward. Before we conclude, I'd like to please ask you to take a moment to answer one final polling on the role of immunotherapy in the definitive treatment for patients with head and neck cancer. Thank you very much for joining us. After the session concludes, please visit peerview.com/2025HNC to claim credit and access the activity materials, and stay tuned for an enduring event based on this event. Thanks very much.
Thank you very much.